but occasionally voriconazole and itraconazole you'll have a prior predilection to use for patients with Candida or mold infections. These two drugs are the most notorious, okay? There are no well-defined parameters on how to dose adjust any of these medications when you use them together. And actually, one of the gentlemen who trained me in Chicago did his thesis on VORI, and there are multiple enzymatic pathways that are not even characterized with this drug that are inhibited from all sorts of metabolic processes. So if you can avoid those two, we suggest avoid it, but there are some issues with patients who have mold infections. Alternatively, fluconazole does go through some citrate form metabolism, but unlike the other three drugs, it is willingly eliminated. It's not fully pathway eliminated, so it needs to be used with caution with tyrosine kinase inhibitors, but it's not an absolute contraindication. The two antihypertensive drugs, rapamycin and diltiazem, used for weight control and blood pressure control, you go through CYP3A4 metabolic pathways. Okay, if you need alternatives, you can always use beta blockers, and they should be avoided with naloxone, just because you can have increased cardiac toxicity, which I'll talk about in a while. The antibacterials, the erythromycin and erythromycin class, do go through CYP3A4 metabolic pathways, so you can increase the levels as well. But clarithromycin especially can have cardiac issues with prolonged QT interval, as well as azithromycin. I didn't put azithromycin on here as an inhibitor because it technically isn't that great of an inhibitor from a hepatic standpoint, but you still get the cardiac toxicity. And then patients on dyslipidemia medications like simvastatin or atorvastatin. Alternatively, you can switch them to pravastatin or Pravachol, which has no CYP3A4 inhibition. The third type of drug interaction is increased toxicity